Good morning, and again, welcome to this episode of our series of YouTube lectures. You can see these lectures in Painfree Partha on YouTube and follow me. And also, the slides are freely downloadable from the website www.painfreepartha.com. So, a warm welcome from our institute. Why should the topic be little difficult? Now you see pharmacokinetics and pharmacodynamics. That itself is a little confusing. What does the drug body does to the drug? Drug dose versus drug concentration. We have given 100 milligram. It is supposed to keep in the blood or whatever it is concentration as 1 microgram. What are the things which affect this? Absorption, metabolism, all these things. That is pharmacokinetics. Now the blood has got 1 microgram per ml. How does it produces the effect? Now there is some problem in resistance of the receptor. The number of receptors may be less. All these things form the pharmacodynamics. Why should we know this? Because this fellow, when he sang the song Muppadu Kodi Mugammadayal, it was 30 crores, and now we have become 130, 140 crores. How does this topic becomes difficult? Because pharmacokinetics and dynamics itself is very difficult. And if you go to obstetric, the spelling itself is difficult. So much confusion. So by the time who is benefited, you can see the faculty, 25, any audience may not be benefited at all. So listen carefully to get more benefit from this lecture. Pharmacokinetics. What is this? Absorption, distribution, metabolism, and elimination. This is what we've been told for long years. Absorption of enterally administered drug may be affected because we know the stomach is pushed like this. There may be early vomiting 2-3 months. All these things make up absorption of enterally admission. Enteral means through the stomach. Parenteral means other than the stomach. So enterally administered drugs may be affected by pregnancy associated GI upsets. Owing to increased minute ventilation, already we have told absorption of inhalational agents may be rapid. This is what is about absorption. If you go to distribution, there is increased blood volume. We all know in the previous slides. There is a lot of changes in the blood volume, CVS, RS, CNS in pregnancy, which we have already talked about in a previous video. There are decreased plasma protein. Fetus is an additional component. Labor pain changes pH levels. All these things make difficult. So liver root, no problem. Metabolism. Pseudocholinesterase, there may be 30% reduction. Since glomerular rate is increased in pregnancy, clearance of many drug is increased. So that's a big advantage. Fetus over neonate. Okay, it can get it back to the mother. That's an advantage. So glomerular filtration rate may be increased. Even the creatinine will be in 6.4 in pregnancy. So plasma volume increase, albumin decrease, GFR increase. These are the things which can affect the pharmacokinetics of any drug. So lipid solubility, protein binding, pKa of the drug, pH of the fetal blood, blood flow area. All these things matter whether the drug will go to the fetus or not. This is what is given as a formula. This is the transfer. dq by dt is a transfer. Now this is K is constant. A is the area. Placental area is big. This is the concentration gradient between the mother and the fetus divided by thickness of the placenta. If it is thick, then it is null. Now you go again. For the drug, constant remains. If the area is high, if the maternal concentration is high, for example, we have given 100 milligram propofol rather than 50 milligram propofol, then the concentration is high. Area of the placenta is high. The thickness is less, then your transfer is going to be high. Now, if area is less, thickness is high, and the gradient is less, then we are going to have a transfer of drug as less. This is very simple. K into A into Cm minus Cf pi divided by D. Then you call this is what is the transfer. lipid solubility, protein binding, pKa of the drug. So it is very clear. Sometimes it may not be very clear. Again, read this. So we have told that K, that is one constant for the drug. What is this K being influenced by? Because dq by dt transfer is equal to K into A into Cm minus Cf by D. D is thickness, A is area. There, K is there. What is this K about? K is about a drug's constant. It depends upon the molecular weight, lipid solubility, pKa, protein binding. All these things. Now, one more thing we have told. Thickness may decrease at term, but at term area increases. A by D சொல்றோம். D it is in the denominator. A is in the numerator. So area increases by term and thickness decreases by term. So this is what we have. The molecular weight is less than 1000, increased transfer. Charged, uncharged transfer. Lipophilic transfer. Everything. Binding protein albumin is increased transfer. Glycoprotein alpha acid glycoprotein binding means decreased transfer. This is what we need to understand. Albumin binding drugs increased transfer. Decreased transfer also. If the free bound unbound is high, then it increased transfer. Now you go again. Molecular weight, charge of the molecule, lipid solubility, pH, placental efflux transport, binding protein profile, all these things makes increased transfer. So there may be a placental depot. Now albumin binding OP, but AAG, albumin binds primarily acidic and lipophilic, whereas AAG binds basic compounds. That is what I told. AAG binding on this side in decreased transfer. So AAG binds more basic compounds, local and opioids. That is why I told increased transfer, decreased transfer. Albumin, AAG. Okay, AAG binding proteins, compounds have decreased transfer. That is local anesthetics and opioids. So this is about the basic pharmacokinetics. I'm not going to the details. Pharmacodynamics. What is that? What the drug does to the body from the blood concentration to the action. Here, giving drugs to the blood concentration. That is pharmacokinetics. Minimum alveolar concentration of the inhalational agents is reduced. Minimum blocking concentration of the local anesthetic is reduced. So, for example, blocking concentration is going to be some 10 mics per ml for lignocaine. Take it like that. Don't directly correlate. And here we may need only 6. That is what is the minimum blocking concentration. MAC is also reduced by 30 to 40%. Now we will go to the individual drugs. Local anesthetics, increased progesterone levels, increased abdominal pressure and epidural space, pain and tachypnea causing respiratory alkalosis and a change in pH of CSF. So all these things make local anesthetic to act better. So we need to give 40% less local anesthetic for pregnancy patients. Bupivacaine is extensively bound to protein alpha-1 acid glycoproteins. An increased percentage may remain unbound in maternal serum compared to non-pregnant. But if you have liver, kidney, it is the same. Almost the same for lignocaine and bupivacaine. The higher the pKa, the more ion trapping can occur. So bupivacaine is more susceptible than mepivacaine on the basis of pKa. So this is very important because I already told you the previous testing. What is ion trapping? So pKa higher, they are more susceptible to ion trapping. It goes in there, the pH is less, it cannot come back from the fetus to the mother. That is what is called ion trapping. The more protein bound, the less impact pH has on the local anesthetic. So bupivacaine is actually least affected because it's more protein bound. The pH cannot influence bupivacaine. That is why bupivacaine is least affected by pH. So local anesthetics have a molecular weight of 250 to 280. So less than 1000, increased transfer. Animal studies transfer rate is lower for drugs that are extensively bound to plasma proteins. So plasma proteins, nothing. The ionized form of drugs will get trapped in the fetus so that they will be unable to cross under. This is what is called ion trapping because the pH of the mother is 7.4 and the pH of the fetus is 7.35 or something like that. If it goes from mother to fetus, there the uncharged form will become less. Uncharged form only can get into the mother, so it gets trapped there. The drug gets trapped there in a acidic environment. That is what is called ion trapping. In case of acidotic fetus, you think of 7.32 to 7.38. The pH of the fetus becomes 7.2 because of hypoxia. Yes, large amount gets trapped. This becomes dangerously trapping. Epidural use in cesarean delivery. The fetal free maternal plasma concentration of ropivacaine was almost twice as bupivacaine in delivery. Elimination half-life was significantly shorter than base. This is what is used. Concentration high, but elimination half-life is shorter. So there is not much of difference. Blood levels high, but it goes out fast. Drug interactions, apparent antagonism between 2-chloroprocaine and mu opioids. Opioids has less efficacy and shorter duration of. If using epidural morphine for post-cesarean pain after 2-chloroprocaine, now we give spinal 2-chloroprocaine or epidural 2-chloroprocaine, and we start using opioids, this will antagonize. So this is accumulation of mepivacaine over a period of minutes. Why should we decrease neuraxial local anesthetics? Reduction of spinal CSF volume, enhanced neural sensitivity, increased rostral cranial, rostral spread when injections are made with patients in the lateral position, inward displacement of the intervertebral foramen resulting from increased intra-abdominal pressure. All these make things you need decreased local anesthetics. So pregnant back, you see, more rostral spread is favorable in the lateral position. So what is the essence? Give 40% less local anesthetics in patients with spinal epidural. Drugs en route, epidural epinephrine and chloride, no effect on uterine blood flow. But IV can cause decreased uterine blood flow in animals. We have already told Dexmed F by M ratio is 0.2 only. F by M ratio means fetal by maternal. Labor pain, intra-op, post-op, subcutaneous, everything is given. And many people use fentanyl, pethidine, buprenorphine, and pentazocine. So sulfentanyl has got a transfer of 12%. Pethidine has got a transfer of 100%. But still, a lot of people have used in labor analgesia pethidine safely for many decades. Lipid solubility and protein binding. Again, the same thing comes. Butrafenol and nalbuphine rapidly crosses the placenta. See, the F by M ratio is 0.84. Fetal by maternal. That is maternal 1 milligram. If it is going to be there, 0.84 milligram is going to be there in the fetus. But Dexmed 1 milligram is there, only 0.2 milligram of there in the fetus. That is what is called the F by M ratio. Maternal administration of nalbuphine has resulted in flattening of fetal heart rate. So butrafenol, nalbuphine, no. Pethidine was questionable because it is 100%, but the people have given it. All others are okay, and the dose is the same. Thiopentone, less drugs is needed. 4 milligram per kg, major problems are less. Ketamine can cause uterine hypertonicity. Etomirate not studied much. Propofol, pregnant and non-pregnant, doesn't bother. Propofol and thiopentone, okay. In general anesthetics, in IV injection agents. Ketamine can cause uterine hypertonicity, and etomidate is not studied much. It started from Queen Victoria. Inhalation of cyclopropane or something like that starts. It is there already. I will tell again in labor anesthesia. Agents, there is no difference. All agents are lipophilic, low molecular weight. Mixture of 50% oxygen and antinox is being used. All agents decrease uterine tone, and no agent has got a specific advantage in pregnancy. The liver is the first fetal organ perfused by the umbilical. The liver is the first fetal organ. Substantial uptake by this organ has been demonstrated for a few drugs like thiopentol, lignocaine, and halothane. Because liver, if it is going to be, liver is a direct connection between the fetus and the mother. Now, what is the essence? MAC decreased by 25 to 40% effect, maybe progesterone effect, maybe endorphin effect. This is decreased, but there is not much of change in the pharmacokinetics of many agents. Benzodiazepines can be used to hemodynamically stable patients, but the problem is about floppy infant syndrome has been proved better to avoid. See here, diazepam is a F by M ratio of 1. So F by M ratio of Dexmed is 0.2. F by M ratio of some deuterephenol is 0.8. So we don't want amnesia in pregnant patients. Let them remember about their pregnancy and childbirth. So benzodiazepines prefer not to give. But if it is going to be real okay, then we can give midazolam and lorazepam instead of diazepam. Highly protein bound after local anesthetic will compete with the protein binding, increase the free local anesthetic concentration. So diazepam preferably no, and preferably avoid benzodiazepines because of floppy infant syndrome. Dexmedetomidine 0.12 to 0.2 is evidence of significant due to high lipophilicity. Coronary is less lipophilic. People are using, but still they have produced fetal bradycardia. And I have used almost like 25 mg of IV clonidine before delivery in more than 400 to 500 cases, with one case of some fetal bradycardia. Otherwise, all are healthy. I have used to increase the spinal level and also to give intense analgesia for their so-called peritoneal toilet. Dexamethasone and betamethasone that are often accelerate fetal lung maturity. So maybe so many things are there, but there is no clinical significance of these things. They have been given successfully in many patients. Nowadays, what they do is there's going to be gift babies, IVF pregnancies, precious babies, all these things. They start Vizolone as soon as they are conceived. So before conception also, for implantation also, they start steroids. So these things are started very well now. Their safety is being proven beyond use. Scoring is pseudocholinesterase metabolism. No prolongation due to apparent volume is increased. In postpartum, pseudo remains but volume distribution decreases. So prolongation starts. What happens now? In pregnancy, pseudocholinesterase is deficient. So it is going to be prolonged. But the problem is the volume of distribution is high. So this prolongation is not seen. But once delivery has happened, the pseudocholinesterase problem remains, but the volume of distribution is gone. So if you give choline in the postpartum period, there may be prolongation. In the pregnancy, there are two antagonists. One is volume of distribution, another is pseudocholinesterase decrease. They attack and choline is same. But here after delivery, volume of distribution problem is gone, but pseudocholinesterase problem is there. So prolongation of choline action is there. This is what I want to tell. Vecuronium, faster onset, less dose, less duration, and atracurium, there is no change. So prefer atracurium in pregnant patients. Faster clearance, less duration with vecuronium. So it is better to use because atracurium, there is no change in the pharmacokinetics or dynamics in pregnancy. Drug interactions, magnesium, because we always use this magnesium drug many times in preeclampsia and eclampsia. Produced. Magnesium is used frequently in obstetrics, preterm labor, seizure prophylaxis. Neuromuscular drugs must be closely, carefully in these patients. So magnesium and atracurium, magnesium and vecuronium, whatever it is dangerous. Whenever I GA in a patient, I give GA in a patient with magnesium sulfate. Preferably use this neuromuscular monitor. I start only with 5 milligram of atracurium and see what is happening, and then start giving 5. Because if you give 25 milligrams, we don't know what is happening, and we will be landing up in problem of residual curarization. If you go to vasopressors, ephedrine does not cause uterine artery constriction, but phenylephrine does. Ephedrine causes placenta, but phenylephrine query. So neural concepts, phenylephrine is supposed to be better in treating hypotension, but ephedrine still is going used. Decades it has been used. Both depolarizers and non-depolarized don't cross placenta. Prefer intubate with choline for other reasons and use non-depolarizers. Sometimes if they take a lot of time for incision delivery time and the patient has come out of choline, you can give non-depolarizers, atracurium. Doesn't cross much placenta. Preferably to avoid, if you are given ephedrine, preferably to avoid ergot alkaloids. Because this hypertension, I have seen a lot of cases. If you give methyl ergometrin and also ephedrine, the BP may be persistently high for 6 to 8 hours, even in non-hypertensives. So that is one of the major clinical interactions, ergot alkaloids and vasopressors. Antihypertensives, nifedipine has been given left and right, labetalol has been given, and the other drug is the previously used drugs, alpha methyl dopa. We don't want more catastrophes. This is the Kumbakonam tragedy. Beware of a combination of nifedipine and magnesium. So that is a dangerous combination. Max self has got better uterine blood flow, and NTG may increase UB flow. Labetalol, the most commonly used, see here, F by M ratio is 0.38. That is why people use labetalol rather than esmolol, which causes fetal brady and decreased uterine blood flow. So labetalol is tick, esmolol is no. No AC inhibitors. Lamipral, Valsartan, no nothing, because it may cause renal problems in the babies. The uteroplacental circulation is a dilated, low resistance with limited ability for autoregulation. It may not match placental flow. Intravenous glycopyrrolate laboring have equal effects on maternal heart rate and BP. But scopolamine used in the past has a similarly rapid intramuscular and elimination half-life. So glyco crosses correct. So glyco is okay. Mother profile otherwise. There is no specific advantage. I want to use noradrenaline. I want to use adrenaline. What is the mother profile? Why we are using inotrols is important. No specific advantage over their pharmacokinetic and dynamic profiles. Methyl xanthines, what you call theophylline, deriphyllins. So beware of halothane-induced arrhythmias. It antagonizes pancreatium. Some sort of awakening will be there if you give theophylline. So that is what we should be careful about in anesthetizing patients who are being given this deriphyllin. Anti-aspiration drugs, non-particulate, okay, ranitidine, okay, omeprazole, okay, metoclopramide, okay, ondansetron, okay, but droperidol, no. Anti-aspiration drugs. Gestational age. What is gestational age? 35 weeks, 34 weeks. This may alter placental transfer, although the direction of alteration requires. Although traditional belief holds that placentas for younger fetuses are more likely. It is not that, because I have already told the thickness increases and after some time it decreases, but area increases. So all these things make up for different things. So it is not that immediately younger placentas will allow and older placentas will not allow like that. Heparin, protamine don't cross. Now I have a small thing in this. Understand this slowly. During a contraction, now we are giving epidural. During a contraction, can we inject epidural drug? During a contraction, can we give IV? I'll say. During a contraction, don't top up. Don't give epidural drugs because of the contraction, the spread is high and unpredictable. So after the contraction settles, give the epidural and next 3 minutes there is no contraction. But during a contraction, if you give IV, the uterine vessels are supposed to constrict. So the transfer is less. So just before the contraction is starting, give IV. So contraction is coming, the uterus doesn't allow this. So the IV injection, whatever drug you are given, antibiotic or atracurium, whatever drug, it goes more into the mother. Pharmacokinetics and dynamics, placental transfer formula, what are the factors for K, what are the drugs, local anesthetics are more for alpha acid glycoproteins, what happens in induction, thiopentone and propofol is okay, inhalation agents 40% reduction, local anesthetic 40% reduction, max alpha, nifedipine dangerous, glyco is okay, atracurium is okay, heparin and protamine don't cross, Fenpress is okay. Droperidol, no. All other drugs are okay. Ranitidine, esomeprazole, omeprazole, pantoprazole are okay. So sheep placenta, all these studies, and can we equate with human? We should know these nuances. Placental transfer dq by dt is equal to K into A Cm minus Cf divided by thickness. Yes, we should know these nuances of transfer. But what are more problematic? Hypotension, hypoxia, hypercarbia, acidosis. These are more teratogenic than whatever that thiopental crosses. Beware, don't allow hypotension, hypoxia, hypercarbia, acidosis. They can cause more problems to the fetus rather than your pharmacokinetic nuances. Think drug necessary, then administer. This everywhere on acetone, all these things. Nothing like that. Think whether the drug is necessary, then administer. Thank you all. This is YouTube. Thank you.